Thank you for your welcome, and it's lovely to talk to you in Slovenia. I'm speaking to you from just outside Oxford, and where we have a beautiful spring day, and it's a lovely evening now. So the question of euthanasia is one that has been of great concern over the last 20 or 30 years in this country and increasingly around the world. I am, as Linda has explained, I am a doctor who looks after cancer patients, and this has come as part of my clinical practice because I have had people talk to me and ask questions to me about whether I could help them end their life. So this has come to me first and foremost as a very practical matter. Our societies have been changing over the last 50 years or so. We have become increasingly affluent, and our experience of death is something that is becoming much more remote. Death is something that we are afraid of. It's something that is often hidden away in hospitals. It's something we don't know very much about. In previous centuries, it was much more something that people were aware of. But now it tends to be shut away. And we thankfully live extremely healthy lives. We are, very many of us, blessed with good health and surrounded by people with good health. And these things lead us to look with increasing anxiety about the process of dying. So as people look at the question of what will happen to them in the future, if they do think about it, as many people don't, they want to control their death. They want to think about how they can not lose control as they become ill. So these factors in society, coupled with, I think, a decreasing faith in God or the afterlife or your spiritual perspective, have led to an increasing call in some societies for a change in the law so that we can control our death as we seek to control many things in our life. And that's what we're going to talk about this evening. So we talk about a word, euthanasia. That actually means a good death. And of course, a good death is something that all of us want. Nobody wants a bad death. If we're going to die, we want a good death. But what that word means, in fact, is that you are going to ask usually a doctor to give you medicines that will end your life, that will kill you. So euthanasia is the ending of a person's life at their specific request by a medical intervention. Now, I'm not sure whether any of you are medical students, but I'm going to assume that you are not. So I'm going to try and put it in non-medical language. When euthanasia is done, it is an injection of usually two medicines, one of which paralyzes the person and the other one stops their breathing. It's the same medicines that are used in some American states where they use it to end criminals' lives. There is no medical benefit for this intervention. It is not pain relieving. It is simply to end the person's life. And in that process, you are asking, the person undergoing euthanasia is asking a doctor to take that act and to end their life. So that is euthanasia. It's the same thing as when a vet, you take your dog, your elderly dog, to the vet and they are put down. The same thing. There is another term called assisted suicide. And in the UK, it has been assisted suicide that has been sought to be legalized. I understand that in Slovenia, there is a bill that is thinking about introducing euthanasia. So these are slightly different. In the Netherlands, they have legalized euthanasia. In Oregon and Canada, they have legalized assisted suicide. So let me try to define what assisted suicide is. Assisted suicide is when a doctor prescribes a big dose of medicine, usually a large dose of a barbiturate, but the patient takes it themselves. So it is the doctor assists the patient in committing their own life by prescribing and providing a large dose of a lethal medicine. But it's actually the patient who takes the medicine themselves. Now, this is all a bit technical, but I do want to take you into the medical ward. And can you imagine walking with me onto the cancer ward? And in the first bed, I see a patient who is in pain. And they are taking some, we're already prescribing some morphine medicine. And morphine is a very good painkiller. And they are in pain. So we want to increase that dose of morphine to control their pain. And morphine, some people think that giving morphine is a way of undertaking euthanasia. In fact, somebody recently went to court so that to be asking for permission to be given morphine for pain relief. This is crazy. This is normal medical practice. We use morphine to relieve pain. But when you use morphine to relieve pain, what you do is you give just enough dose to relieve the pain. You don't use a massive dose. You use enough to achieve your objective. And it's very different from giving a lethal dose of drugs. Your intention there is to relieve suffering. There can sometimes be a situation where somebody's pain is very difficult to control, and we need to increase the dose to a level where it may affect their breathing. But the same principle applies, that you're applying the minimum dose to control the symptoms. And even if you recognize that in some rare occasions that might shorten their life, your intention is not to shorten their life, it is to relieve the pain. So don't be confused by thinking that euthanasia is the good use of pain relieving medicines. The second thing you mustn't be confused about is that is about the withdrawal of medical interventions. So imagine somebody has just had a road traffic accident and they're taken into hospital. And initially they're not sure whether they are going to survive or not. So they're taken to the intensive care unit and they are ventilated. And over the next day or two, it becomes apparent there is no sign of recovery. And tests are done, and it shows that that patient is actually brain dead. That is, there is no brain function. So a decision is taken to switch off the ventilator. That is not euthanasia. That is withdrawal of a medical intervention which is accomplishing nothing. And there are other situations where we may withdraw medical interventions because they are futile, because they are achieving nothing, they are pointless. And that is something that's an inevitable part of medicine sometimes. So the use of pain relief is not euthanasia. The withdrawal of medical intervention is not euthanasia. The non-use of possible intervention is not euthanasia. So in medicine these days, there are many things that can be done, but not all are appropriate. So, for instance, an elderly lady, my mother is 104, would you believe? She's frail. She's very frail. And recently she had some urinary symptoms, and it was not clear that it was an infection, but we decided we would not treat her with antibiotics. It all went away and she's carried on in her current state. But we decided not to use an intervention, which we could have done because it was not relevant for her. We are not called to prescribe a lingering death, to keep on doing things to people, to keep them alive when they're dying, to draw out their death. So we may not use possible interventions. All of these things fall within the normal part of medical practice. And it is right to make these decisions. All of them are lawful. What is different about euthanasia is that it is an act which is directly, the intention of the act is to kill the person. There is nowhere else in medicine where we do something with the direct intention of killing people. And yet this is what the law, some people are proposing. So I hope that helps you understand a little bit that the way euthanasia is different from many other interventions we do in medical practice. It's categorically different. It's not trying to relieve suffering. It's trying to kill the person. That's the intention. And again, the difference between euthanasia, which is the active act of ending a person's life by a doctor on the end of an infusion, versus patient-assisted suicide, which is where the doctor provides the means to end their life, but the patient takes the medicine. So what could be the motives for this? Well, one of the main motives that comes up, the claim is that this is compassionate. It is compassionate because it's relieving the person's suffering. It's relieving the person's suffering in a particular way by ending their life. Compassion, much more normally, is used as a way of relieving their suffering within life, and that certainly is important. And compassion is a fundamental aspect of all good care. So compassion is not an adequate explanation or motivation. It is often a desire for control. If you look at the statistics about the people who ask for euthanasia or assisted suicide, and this has been done in Oregon, you see that there are a very increased proportion of people with bachelor's degrees. About 50% of the people ask for bachelor's degrees, so university level degrees. So mostly these are well-educated people. Very few of the people asking are from lower socioeconomic class, shall we say. So these are usually educated people who are wanting to keep control of their lives and their death in that sort of way. And autonomy is the argument. Autonomy is a Greek word meaning you're setting your law for yourself. In the old Greek times, they talked about autonomous cities. So a city was not under the rule of Athens. It set its own rules. So it was about a community that set its own rules. Now, in modern parlance, in modern usage, we've gone on to say that an individual can set their own law. That's an interesting question, isn't it? Can we set our own law? No, we don't. We actually live in community and we have to think about everybody else. But autonomy has come to be meaning I make my own decisions. As long as it doesn't upset anybody else, I should be free to make my own decisions. And it's that's a major driver of the desire to, to legalize euthanasia. People say, it's my right to die. It's the ethics of choice. So what is the law at the moment? I've said that the law at present in the UK is that it is against the law to assist somebody else's death, either by a physician-assisted suicide or by euthanasia. That is against the law. And we have, and I'm sure that's the case in Slovenia now. Over the last 20 years, we've had a number of attempts to legalize euthanasia or physician-assisted suicide, with a number of cases going to the government. On every occasion, it has been very clearly overruled and thrown out. It is the case at the moment that about 20 cases per year in the UK are referred to the Department of Public Prosecutions. That's the lawyers who decide whether to make a case. So these are cases where somebody has helped a relative to end their life. All of those acts are against the law, but the Public Prosecution Department doesn't necessarily have to prosecute them. So let me tell you about the policeman's dilemma. So the policeman's dilemma is often used by people who support euthanasia. And it goes like this. There was a case in America where a driver was trapped in a burning lorry. Can you imagine a horrible situation? The driver could not get out of the cab. He could not be released because he'd been in an accident, and the lorry was on fire. There was no possibility of getting him out, extricating him. And he was about to be burned to death and to suffer a very painful end. A policeman was on the scene, and he asked the policeman, "Will you shoot me?" And the policeman did. Now, that is often put to people in the euthanasia debate, saying, here is a terrible situation of somebody about to suffer terrible and immediate death in a traumatic situation. Would you kill them? Should the policeman shoot that man? And in our hearts, we say, well, yes, perhaps that's right that he should do it. What do you think? Should the policeman kill him?
I would say no.
You would say no. Why would you say no, Clara?
Well, who am I to take, like, even if a guy says to me, like, kill me, I would say I'm not the guy. I'm not the one who will choose if you're going to die or not. I mean, if you are the one to die today in these circumstances, you're going to die. But I'm not going to kill you because, first of all, I don't want to have a death of some person in my head. I mean, in my hand, and at the same time, it's just not right for me.
Okay, and many people agree with that. Anybody else want to join in and contribute? What would they say about the policeman's dilemma? Okay, so on this occasion, so often when you put that out, some people agree with Clara, and other people say, yes, he did the right thing. And the presumption is that if you think that the policeman should have shot the man, then you should agree to legalize euthanasia. But there's something wrong here. On one occasion, one of the witnesses gave a response. It's a hugely compassionate case. It's a very difficult case. But I would do exactly as the policeman did, and I hope you would too, but I would not expect the law to be changed to allow that. Now stop and think about that. Would it be good to change the law so that policemen could shoot somebody who was in a difficult situation anytime he came across them. No, of course it's not right to do that. It's not right to change the law. And yet this is what the euthanasia supporters are saying. We have some very difficult situations where somebody is crying out to end their life. And therefore we should all change the law. It's not the right thing to do. It's right that it remains illegal to end somebody else's life, even though there may be occasional situations which are very extreme where you might break that law. And then it's up to the country to decide whether that's been right or wrong. The law courts do not have to prosecute everybody. And if they judge that this was in good faith, then they may not prosecute. So let's go on to think about what has happened in the countries where physician-assisted suicide or euthanasia have been legalized. And because euthanasia is what's being considered, most of my remarks will be related to the Netherlands, where this was changed about 15 years ago. So there's an interesting graph here. I'm sorry I haven't got a very good slide for you, but I hope you can see this. Can you see this graph? Can you see the trend? I think you can.
Yes.
So it starts on the left in the year 2002 with 1,882. Those first few numbers are between 1,880 and 2,000. And for the first 4 or 5 years, when after euthanasia was legalized, the numbers in the Netherlands remained steady. And people began to think, well, this is okay. There is not a big change. But then over the next 10 years, between 2006 and 2016, the numbers of recorded cases in the Netherlands of assisted suicide and euthanasia rose from around 2,000 to 6,500. So there was an enormous expansion in the numbers of patients who were having euthanasia. So of those 6,000 odd, about 4,000 were people with incurable cancer. Other included nervous system disorders, cardiovascular disease, lung disease. A number of people with psychiatric illness. In 2011, there were 13 cases of euthanasia involving people with psychiatric conditions. By 2019, this had been risen to 68. And similarly, dementia rose from 49 to 162. 172 deaths were accumulated from an accumulation of old age disorders. There's so an increasing number and an increasing range of diagnoses. There's another very concerning thing that was reported in the Lancet. They reported the Remelink report regularly. And in 3,700 cases of euthanasia, of 1,000 were terminated without a specific request. In other words, there was a beginning of a change that people were not just undertaking euthanasia on request, but on a condition. So what is happening here? What's happening about people's attitudes? What are the risks that follow? So one of the key things I think that's happening is that people are, the medical profession and society is being acclimatized to the it's normalizing the active ending of people's lives. So in oncology, in my specialty, when you're dealing with somebody with metastatic cancer, that is some cancer that has spread and is no longer curable, I'm told from colleagues in the Netherlands that maybe not in the first consultation, but in the second consultation, doctors will now offer euthanasia as one of a range of treatment options. So patients might consider, well, would you like some chemotherapy or palliative care, or you could have euthanasia. And it's just become part of normal medical practice. There is a normalizing effect on staff. Linda, you're going to be a nurse. When you have been involved in an event once, twice, 3 times, 4 times, you have to something goes on inside you. You want to make that a normal event. You no longer see that as something which is abnormal. And it becomes normalized. You sort of justify yourself. And yet, in fact, what happens is that doctors are saying, this is not what I came into medicine for. Somebody's waiting to come in, I think. So there's one very telling comment from a doctor in the Netherlands. Where have I got that? I just want to quote this for you. Dr. Boer, for the first 5 years after the law became effective, such physician-induced deaths remained level and even fell in some years. In 2007, this doctor wrote, there doesn't seem to be a slippery slope when it comes to euthanasia. A good euthanasia law, in combination with euthanasia review procedure, provides warrants for a stable and relatively low number of euthanasias. Many of my colleagues drew the same conclusion, but we were wrong, terribly wrong. In hindsight, the stabilization in the numbers was just a temporary pause. Beginning in 2008, the number of these deaths show a 15% increase annually, year after year. I used to be a supporter of the Dutch law, but now with 12 years' experience, I take a very different view. At the very least, wait for an honest and intellectually satisfying analysis of the reasons behind this explosive increase in the numbers. Is it because the law should have had better safeguards, or is it because the mere existence of such a law is an invitation to see assisted suicide and euthanasia as a normality instead of a lasting resort? Before these questions are answered, don't go there. Once the genie is out of the bottle, it is not likely to ever go back again. So there's a real warning here from a society which has an extremely good medical system, full of very compassionate people with a strong Christian heritage. And yet, even in that environment, euthanasia has become normalized. So much so that even people with psychiatric conditions are having increasing numbers of euthanasia. Now, one of the key things, let's just think about that for a minute. What is one of the key symptoms of psychiatric illness? It's depression. And depression has as a consequence a desire for suicide. And yet we know that psychiatric illnesses wax and wane. People can be treated and can recover. And yet here we are in a humane, Western, advanced society like the Netherlands, where patients are being actively killed with psychiatric conditions. Beware. I think when we step back from that, there's another 2 aspects I want to mention to you. The first of those is about patients' perception of advancing disease. There are 2 sides to this coin. It constantly amazes me that when I talk to my patients with advanced cancer, many of them are still so positive about life. They know that they are fading, they are weakening. They know that their they're coming towards the end of their lives, and yet they're still appreciating their lives. They're benefiting. I once had a medical student who was from Serbia, not so far away from you, and he'd been working with me for 6 weeks. And he said, I don't understand it. Here, you tell everybody they're going to die, and they're all happy. In Serbia, we tell nobody they're going to die, and they're all miserable. So why is that? I think there's something about talking truthfully to people that actually sets them free. Jesus said, you shall know the truth, and the truth will set you free. Well, he wasn't referring about the truth about their medical condition, but it's still the case that when you talk truthfully to people, it does free them. It frees them to be able to come to terms with what's happening to them. It gives them permission to talk to their families and to have those really important conversations that often happen towards the end of life. I don't know whether any of you have experienced that precious time of talking to one of your relatives or an elderly, a grandmother or grandfather or somebody who is not far away from death, and the value and the importance and how memorable it is, those last conversations. There are so many last conversations which are so vital, and euthanasia can stop those happening. I'll tell you another story to keep you awake and involved. I remember when on the ward, I came in and saw this man, and he had lung cancer, and he had involvement of his spine so that he couldn't really stand up properly. And he said to me, Doctor, this is terrible. I can't do anything. I want you to help me end it all. And he asked the classic question, I want you to help me end my life. So I sat down with him and I asked him more about himself. And it turns out that he'd been a golf professional. So he'd had his life training people to play golf well. And he had a house that belonged to the golf club. So he lived on the golf club. It wasn't his house. And when he died, his wife would have to move out. And I asked him, well, have you got a plan for where your wife will go? No, hadn't thought about it. And then I asked him about his family. And he said, well, he has 2 sons, but one of them he hadn't seen for 17 years. He said, do you want to see him? Yes, I'd love to see him. I want to see him more than anything. So suddenly, in the course of just a relatively short conversation, he found 2 things. Even though he couldn't walk, even though he was short of breath, even though he was in pain, he found 2 really important things that he could do with his life that would be of tremendous value and give him dignity. He could help his wife sort out her future living accommodation, and he could make contact with his son and have those precious conversations. He never mentioned again the desire to end his life, because he realized even though he was ill, he still had very important role in life. How many of these people who are reacting to the depression and hopelessness in the face of serious disease, which is so understandable and so real, and yet people come through that to realize that even though they have serious disease, there is still value in their life and still important things to do. I'll tell you another story. The first man who had euthanasia in the Northern Territories of Australia was a man with prostate cancer. And you won't know this, but many people with prostate cancer have very good treatment result from a hormone therapy. The prostate's under testosterone control, and you can inhibit the testosterone, and patients improve and they have a pain-free, fully active life for a number of years before their cancer becomes resistant. And here was this man who was very much a go-getting, I can solve this sort of man. And on the Friday, he saw the oncologist, who was the man who told me this story. in fact, sorry, it's the palliative care doctor, because he had some pain, but actually he was no longer in pain. But he was just facing the fact that he had incurable disease, and he was distressed. Now that, in my experience, is something that it's a terrible thing to face, but when you face it, you come through it and you realize, well, actually, we're all going to die one day, and here is now the time. Now I know what I'm going to die of, but I've still got life ahead of me. But this man, by the next Wednesday, was dead. He'd gone to the euthanasia doctor in Northern Territories. He was the first person after the law was changed to be allowed to have euthanasia in Northern Territories. He said he wanted to end it all, and the next day he was killed. Now, I'm absolutely certain if that man had lived for another month or two, he would have come through that acute depression and would have had a very different opinion. He would have gone on to have 2 or 3 or 5 years of good quality life before he ran into further problems. So there's a real risk in legalizing euthanasia, because it puts this group of patients into a position where they can just jump and get it done, and they don't have the time to work through what's happening to them. There's another group that I'm very concerned about, and that's the group of people who are wonderful people, but who feel that they are a burden on their families. Elderly people who've given their lives to bringing up their children. Now they're ill. Now they need to be looked after instead of looking after their offspring. And they feel a burden. It might be a financial burden. It's a burden of care. And these people are also asking for euthanasia. In the data from Oregon, this was one of the high causes of people asking for euthanasia. Yet these people are people who are vulnerable. Remember, the first duty of law is to protect the vulnerable. And these people are vulnerable. People who are facing a terminal illness are vulnerable, and we need to protect them, both from that sense of being a burden and therefore being done away with, from the consequences of their own short-lived hopelessness. And remember the rest that I've referred to before about the normalizing effect on staff, the way this becomes normal. Now, I just want to end up with something that's positive. So I've said a number of reasons why I think euthanasia should not be legalized. It leads to an increase in numbers, and the same has happened in Oregon and Canada. I could show you the graph. It puts people at risk. The current law is actually working very well. But it's important that as Christian people, we think about the alternative and we work for that. So I've mentioned truth-telling. We need to be training our nurses and our doctors and our people involved in care of the dying to be able to talk well to people about the reality of their death. So this is something that I do in my clinical practice. Last Friday, I had 2 very extraordinary conversations with people, both in their 50s, with terminal cancer, explaining to them that the end was coming. And they want to know, they want to be able to talk to their families. And we must, as doctors and nurses, be able to do that. We need to be able to offer that to them, telling them the truth, enabling them to have those conversations which are so important with their family, enabling themselves to prepare and to think. The second thing is we obviously need to relieve distress. And it was about 60 years ago now that a lady called Cecily Saunders, She was a remarkable woman. She was a devout Christian. She was trained as a nurse, as a social worker, and as a doctor. She had 3 separate qualifications. And she pioneered what we now call palliative medicine. That is medicine not with the intention of cure, but with the intention of relieving suffering. Now, in every hospital in the UK, there are palliative medicine doctors who will actively work with patients who are dying to help relieve their suffering, relieve their symptoms. They will operate in a team with people who can look at the emotional needs as well as the physical needs. They will treat people with dignity. They will talk to them truthfully. This is the important thing. And I don't know to what extent that movement has spread into Slovenia. But if any of you can have any ability to relate to that, to link up with it, to expand it, then I encourage you to do so. And my last point is that the word dignity comes into this debate often. And many of the people who talk about legalizing euthanasia talk about dignity in death, that you retain dignity by retaining control. Actually, we can give people dignity by the way we treat them. If you see a patient who is suffering, who is alone, who is anxious, you give them dignity by sitting with them and treating them as a human being, as somebody who you're going to give your time to and your love to. And that is really where dignity is here. It is something it's an extraordinary gift that we as caring people can give to the dying. And I'm full of admiration for my colleagues who, even more than I do, work with the dying patients and who day after day are bestowing dignity on people by the way they care for them and love them, just as Jesus did when he bestowed dignity on the sufferers with leprosy. So there's an overview. I would, just in summary, I would encourage you to understand the motivations of people who want to change the law. They are not wicked people. They are people who are trying to work through what's a difficult problem. But I hope I've given you reason why we should not change the law. If you change the law, there will gradually but persistently be a normalization of death being delivered by medical care. And it will increase and it will increase. That increasingly puts at risk the vulnerable. The vulnerable, whether they be people with mental illness, other illnesses, people who are suffering with depression and hopelessness or feeling a burden. And we should not do that. The alternative is to care for people, tell them the truth, and to continue to treat them with dignity. And that is a very real and evidence-based alternative. Thank you. Be very happy to answer any questions.
Thank you for everything you have shared with us. Well, now it's time for a Q&A. We have a few questions for our participants. So the first question is, which age group is most likely to choose euthanasia and for what reason?
Okay, so that's it's the sort of 60s and 70s age group, often male, often, as I said, the more educated. There's a phenotype of the sort of businessman who has always made the decisions in his life and who wants to carry on making the decisions in his death. The man who has controlled his life. And I think it's very difficult for men. I've seen, many men who have had successful, active lives, when suddenly they're first confronted with a situation which they cannot control, and they want to retain control, and so they ask for euthanasia. So that's the sort of classic phenotype, the male controller, if you like, who wishes to ask for euthanasia. And that's the people who you'll often see leading the debate.
Most people would argue that they have a right to choose whether to live or die. What fault do you find in that line of thinking?
Rights are, we claim rights. Do we have a right? Do we have a right to die? We all will die. In the case of people with mental disturbance, psychiatric illness, we certainly don't consider that they have a right to suicide. We don't, it is not criminalized anymore, but the whole of the psychiatric services are geared towards helping people to avoid suicide. So we don't actually think that mentally ill people have a right to die. It's no longer a criminal act to commit suicide, but it is, we try to protect people from that. So I think it's using the language of rights, which we appropriately use in some settings, and extending it into another setting, which I don't think is where it's not really justified. And what does it mean to have, we have a right to die? We will all die. What you're saying is we have a right to control the circumstances of our death. Well, do we? Why do we think that? I saw a good question popping up in the chat. You said that euthanasia limits the opportunities for dying people to have last conversations with their loved ones. Surely it's the opposite, given that euthanasia, you have an exact time when you will die rather than not knowing. I think that's there is definitely some truth in that, if it's all planned out and you have the family with you. But I think what can happen, I've not worked in a situation where we have euthanasia. But it's certainly the case in some situations where people don't actually face the issues and don't have the last conversations. I think that person's made a good point, but I don't think the opportunities for facing death when you are in the situation with normal care, you should be able to have those conversations with people effectively.
Do you know how common the desire of artificial induced death was before the modern form of euthanasia? And did this practice also occur a century ago, or is it linked to today's pagan culture and the absence of the value of life?
So I think your question is, what was 100 years ago or so, what was the way that people talked about euthanasia? Well, talked about I don't think I know the answer to that. I know that I don't think I know the answer to that. What was happening 100 years ago? People knew about the use of opiates, but they had no idea about the right dosage. They would talk about grains of opium. They had no precise way of measuring dosage, maybe 150 years ago rather than 100 years ago. So there was much more variability in when you gave somebody a dose of morphine. You didn't really know what you were going to do. So it was much more difficult to control that. But I really don't know enough to be able to answer that question very well, I'm afraid.
Okay, we have one more question. If in the Christian circle, if God is kind and loving, how could he allow people to die horrific and agonizing deaths when there's an efficient and pain-free option available for them?
So there are a couple of levels I would like to address that on. Let me just turn to something over here. So I think the Christian framework is that life is sacred. Life is something that has been given us by God, and it is something wonderful and precious. All life is from God, and that human life is made in God's image, so it is precious. The second Christian principle is that death is inevitable. It's going to come to all of us, but that it's not the end. There is eternity as well. The third is that suffering is not the ultimate evil. And remember that Jesus died a most horrific death. So God is not sitting in judgment at a distance in this situation. He himself died a terrible death for our good, for our forgiveness. And that is something he willingly did out of love for us. So we need to see beyond the fact that pain is pain is pain, that's terrible, that's all there is that's bad. Pain is nearly always relievable. So the dichotomy of leaving somebody to die in terrible pain versus an efficient death is not a correct comparison. And above all, love. So our concern here is to love and care for the suffering. And what I hope pointed out is that to change the law so that some people can have an efficient death risks threatening a far larger number of people who don't want that death, but who are put at risk of being brought into a healthcare system where it is increasingly normalized that people will have their lives ended. I think we create far more danger by legislation. So what's the difference between killing an animal who's in great pain and won't recover and a human? Well, the difference is that we are humans. We are made in God's image, and we are precious. We are of eternal significance. So there's a huge difference. So I think that there is a real depth and reality to the Christian understanding of this. But what I also want to show to you is that there is a valid empirical argument against it as well, in terms of the greatest of risk to the greater number by legalization of euthanasia. You don't just have to defend the argument against euthanasia on a Christian argument. It is very valid to defend it with no basis in faith, whether that be Christian or Muslim or Jewish or other. Though it is notable that people of all those faiths will stand against it.
Some question: if we let someone live by not trying to end the pain by euthanasia, we are prolonging the pain, misery, and suffering. How is that the good or moral thing to do?
So, as I've said, you will work hard to relieve that pain so the patient can be free of suffering. And what is striking is that people, it's very easy for us as healthy people, particularly for younger people, if I might say so, to say, I could never endure that thing, that situation. But as people go ahead in their disease, millions of people who are dying still value life. Some people who are dying don't value their life anymore and want to end it. But millions of people still value life, even though it is limited and maybe painful. And so it's not black and white like that question suggests. If you're in pain, you want to end it all. No, millions of people have pain, have struggle, but still value their lives and want to go on living. And we threaten that group of people who are already vulnerable by this change in the law. Why should we make them, those people who are vulnerable and suffering, the one group of people in society who we will allow somebody else to kill? They most of all deserve our protection. It's a difficult question. People, it's a difficult argument because people come in with this sort of black and white things. How can it be possible that it could be compassionate? But you need to look beyond that to see the other people who are also suffering and yet want to live and who are threatened by the law change.
How can we as a Christians help people who are considering euthanasia in a practical way?
So I've tried to illustrate that for you by the conversation with the man who was the golf professional. So it's about helping people to think about their relationships. It's about helping people think through truthfully what is happening in their lives. And it's about proactively working to create an environment where they can be cared for and treated with dignity and find that they can still value their day-to-day life and their relationships.
What is the difference between suicide and euthanasia? Why does people choose to go to hospital and ask a doctor to get an euthanasia rather than just take a life for themselves? What's the difference?
Okay, so the difference technically is that in euthanasia, a doctor will stand there beside the bed and inject a medicine into the vein that will kill the patient. In assisted suicide, or in suicide, the patient takes the act themselves. So the patient ends their life. In assisted suicide, the doctor helps the patient do that by providing them with a prescription for drugs that they can take to end their life. So the doctor is one step away, if you like, by providing the drugs to the patient, that the patient will then take the act themselves. So why do we prefer, or why does one situation operate with a euthanasia and another with patient-assisted suicide? I think the range of options, the range of interventions. If you have a euthanasia, you'll find that the numbers are far higher for people ending their lives. That's the situation in the Netherlands. If it's patient-assisted suicide, then the numbers, although rising, will be proportionately less. So in the UK, where we've debated it, we've thought that euthanasia is too dangerous, it's too open to abuse. Whereas assisted suicide, at least you're leaving the final act in the hands of the patient. So it's a little bit more safe. So we very quickly turned away from euthanasia, but had significant discussion about assisted suicide, but decided that even that wasn't safe enough.
Tim, thank you very much for all your answers. It was really helpful for us. And the questions were also a little bit hard to answer, I believe.
Yes, they were.
yeah, it's not easy topic. So
Yeah.
that's why we are really happy that you are with us today. And on behalf of all participants, I would like to thank you.
It's been a pleasure. It's lovely to see you again. And I hope that you will stand firm about this matter and in everything else.